get started with this session I'm really excited about. It's called Where Do We Go From Here? Virtual versus Vintage Education, because these days I feel quite vintage. At least I can't keep up with all the new applications out there. Our speakers are Guy Carmelli, an assistant professor at UMass Worcester, and Alex Nordberg, assistant professor and assistant program director at UMass Worcester. Thank you both.
Oh, and you said it pretty close, really close. I'm still learning. It's how to say the Worcester in Massachusetts. Before we get started, we have no financial disclosures. Alex, did you want to say something about even my pronunciation of Worcester?
You did pretty good. I'll let it slide. I'll let it slide.
All right. So background for our talk. So COVID-19 has shaken the landscape of medical education, transitioning us from those in-person vintage style of education to a completely virtual experience. Due to the drastic occurrence, a divide between what was, or what I like to call the before COVID BC time, and what is, or the after COVID AC time, has many educators trying to adjust to this new normal. Now that the pandemic is winding down, in fact, the CDC just today said that vaccinated people don't have to wear masks, so that's kind of cool. But lots of people are wondering if these new methods of learning will persist or whether we'll return to the way things were before this all started.
So this talk is formatted a little bit differently. We're doing a structured debate style to kind of compare and contrast virtual and vintage styles of education. We'll identify examples of successful virtual education and hypothesize potential hybrid curriculum models for, afterwards, whatever that is. For the debate, I will be taking on the winning side of vintage education, while my colleague Guy will be taking on virtual modalities.
All right, Alex, put up your dukes. Let's get this debate going. There's no way vintage is going to beat the virtual education.
All right, we'll see. All right, round one. Core content lectures. So both residents and medical students have certain core content lectures that form the basis and the foundation of their education. There are benefits to both virtual and the classic way that lectures have been performed in the past.
Okay, so virtual. So these are our core content where we want most of our learners to be able to attend. Since it's virtual, more residents have the opportunity to log in from anywhere they are, ensuring everyone is up to speed with this core content knowledge. I mean, learners say this content is dry anyway, so why not allow them to watch from the comfort of their own couch? Not only can more residents attend live, but we're able to record these lectures so that these residents who can't attend live can maybe rewatch it on their own time. As we will talk about later, it is easier to get lecturers to commit to giving a virtual lecture. Furthermore, you can have more flexibility with creating the schedule, as you could put various time slots. Residents don't have to drive into the hospital for a didactic, so you can have a virtual lecture at this time and then again at another time. So it's easier to kind of schedule. Finally, there's many creative ways to create an interactive lecture using virtual. There's like different ways you can do shared slide annotation or drawing on the slides, or different polling software that you can use virtual. So that's pretty cool.
Yeah, Zoom's cool. Zoom's awesome. We, can't get enough of it. But, the idea that students and residents, this is their education. We need to make sure that they're getting it. As we all know, attendance does not mean engagement, does not mean that they're actually learning in that moment. How do you know that active learning is happening when you're staring at a black box with someone's name on it? I don't know if they're there, if they're not there, I don't know what they're doing. It's not the same thing when you're virtual versus in person. When you're in person, I'm looking at them, I can pause, I can speed up, I know what to do and how to adjust the teaching points. It's much more difficult virtual to try to do a knowledge check or try to, get that sense of where the audience is meeting you through a computer screen. Vintage all the way.
I don't know, no pain, no gain, you just have to get used to it. All right, but let's go to round two. This is a board prep or standardized test taking. So students and residents are constantly being tested. Shelf exams and the rotation exams, STEP, future oral and written boards. Many rotations and residencies are including education for standardized tests as part of the curriculum. So virtual. So both our written and oral boards this past year are done on the computer. So why not begin to prepare people and residents for getting virtual style questions? Like I mentioned in the last round, we are able to provide virtual review lectures to a large group of learners that wouldn't be able to attend in person. There are many creative ways you can give a virtual board review, such as summary lectures, quick visual diagnosis, identification lectures, some board review gamification. I'm going to talk a little bit more about it in a future round, but my colleague Ronnie Wren and I performed a quarterly board review style trivia game, which we did virtually, which was loved by all the residents. Finally, you can perform virtual oral board style practice sessions to mimic the current virtual oral board platform being offered. So our residency program has been offering it for our residents, and we've been getting pretty favorable feedback.
Yeah, I'll give you the board review course that you and Ronnie created. It was good and it did get a lot of great feedback. But vintage in-person board review, oral board review, it's just the way to go. You can better engage in discussion. I don't necessarily want to know if they know the answer straight up. I want to know if they know why that's the right answer and how to behave and interact in an oral board style scenario. The in-person, it's just easier to have the teacher engage the learner in that way. And in-person also offers the benefit of being able to mimic the exact testing scenario, which can also help a lot of people who might have test taking anxiety. In person. All right, next round, gamification. Learning through games has been around for quite some time. Gamification taps into the competitive nature of learners and allows for group learning, and it's a great way to both test and reward knowledge of certain subjects. Gamification can be done in person and virtually with some benefits to both.
Okay, games, video games. Have you heard of it? Video virtual. I mean, come on. Gamification is all about buy in and interaction between learners. And by going virtual, you can create a competition in like a non threatening venue. As students are at home in a safe space, no more putting people on the spot or embarrassing them with the Socratic style of method. There are many examples of games that could be played virtually. Jeopardy can be made easily virtual. Have you heard of Kahoots? I mean, it's a hoot and it's made for virtual gaming. As I said before, Ronnie and I played virtual board review trivia. Another colleague of ours, Cassie Mackey, put together a virtual escape room challenge, allowing learners to kind of work their way through complex clinical situations in a creative and fun environment. I mean, you can't do stuff like escape rooms in person. There's tons of interactive video games, gaming software, virtual platform learning softwares that are made specifically virtual. Finally, all the games are easier to score and run virtually than it would be if you were trying in person.
All right, Cassie's escape room was great. It was great. But, what you said initially, gamification taps into people's competitive nature, right? I don't know about you, but how competitive are you with this, black box with someone's name on it? Once again, that issue comes up. You can't tap into people's competitive nature when they're just staring at a computer screen. It's much better when everyone's in the same room, you yelling at each other, getting competitive. Everyone wants to be right. Everyone wants to get the right answer. It works much better in person, much better. You get more buy-in, more engagement, people are more excited about it. And yeah, maybe it's a little harder to score, but we don't always take the easy way out here, right? You can also add some physical component to it. Ever heard of Sim Wars, Sono games?
Sim Wars this year was played virtual. Okay, so I think this is a round four is going to go virtual. Discussion-based content. We're talking about wellness. We're talking about ethics, journal club, getting together in a small group and having those discussions. So the flipped classroom has been all the rage of late, focusing on objectives rather than content. Here we have the residents learn the material ahead of time and allow class time to be moderated discussions to understand these difficult and challenging topics. These discussions can be anything from complex medical situations to wellness to ethics to moderated journal clubs on EBM articles. So virtual. So these topics are important to work through. Virtually, you can capture a wider audience, increase opportunity for more people to offer up their experience, opinions, and whatnot. You can use breakout rooms for dedicated discussion. I mean, breakout rooms are made for these kind of small group discussions. Gone are those times where you're like walking around the medical school trying to find an empty room for your small group to talk without being on top of everyone else. You can use social media platforms, Twitter, Facebook, Instagram, YouTube, WhatsApp, Slack. Again, I have no financial disclosures. And you can use all these platforms to further e-learning and can engage outside educators from around the world and various expertise levels. They can all kind of weigh in into the learning environment as well. You can make it an active discussion by having learners use hyperlinks or share their screen function so that the learners can kind of direct the course of the discussion. And finally, residents will all have more time since they're not driving into conference, so they should theoretically be more prepared to read the articles ahead of time.
We all know how that goes. And I don't know where you go for conference, but we don't wander around the medical school. You kind of just book a room ahead of time type thing. But your argument was it was A for effort there, but we're talking about these discussion based topics. This, wellness, ethics, that sort of thing. We're getting into our sense of humanity. So be a human, have some human interaction, and sit in the same room as someone and have this face to face discussion. You can't see emotional changes on someone's face when they're hiding behind their computer screen again. Allie, just kidding. Um, like I want to be there in person, talking to everyone, seeing everyone's face. It's easier to foster discussion, and maybe even a little healthy debate. That's just too awkward over Zoom. You're getting interrupted. You're trying to make your point. It's all just wasted.
I mean, we're having a healthy debate right now over Zoom, so just saying.
All right. Well, only because it's going to be in person. This is a backup. This is a backup plan. All right, so moving on to simulation and workshops. So simulation and education and educated workshops have become a staple to teach many topics in emergency medicine. Residents and students love the opportunity to learn procedures, run resuscitations, and receive feedback on performance from faculty.
Okay, I mean, this isn't virtual strong suit, but there are many innovative ways various institutions are learning to do sim virtually. If you don't want to create your own new curriculum, I'm sure you can just Google or go on Foam and then look at all these people's curriculum that they posted on sim education. Cassie's virtual escape the room that I mentioned earlier was a simulation that can be done. So different kind of video sims, interactive virtual gaming sims, or just a choose your own adventure PowerPoint simulated cases that are out there. Virtually, you can demonstrate different techniques or use specialized equipment that may not be available. You can also set up complex environments that aren't easily reproducible in the real world. So imagine trying to intubate in full PPE while there's vomitus and an attending's yelling at you. I mean, virtual and video games, you can set up almost anything. Our admin put together a sim for intubating COVID patients, which was performed along with our respiratory techs, and it worked out pretty well.
That's cute. It's a cute argument. It's getting there, but the whole point is that these are things that you do in person to gain muscle memory. How are you going to teach someone to intubate over Zoom? It's not going to happen. They can know it, but they won't be able to show you. They won't be able to do it themselves. This is something that is hands down in person, that muscle memory. And you can, of course, create high stakes environment in person. High stakes environment on a computer, I don't know what you're talking about. You can't convince me. In person, all the way for sim.
Yeah, I figured. Okay. All right. So I purposely put this as our final round because I felt like I could get some extra points here. These are our guest speakers or grand rounds. So getting guest speakers to come give a talk to your residents are a challenge, especially if you're trying to get a grand round speaker. However, occasionally you're able to motivate a speaker who don't usually lecture to your residents to give a new type of lecture. So virtual. Like I alluded before, you could possibly motivate more teachers to give a lecture, given the decreased time commitment of giving a virtual lecture relative to an in-person one. People do not have to significantly alter their schedules or life to give a virtual lecture. In fact, this past year, UMass, our institution, have had more grand round talks than ever before. It's much cheaper than having to fly in a lecturer to give a grand rounds or pay for other expenses. And not only does it benefit the learners, but we're able to motivate more lecturers who could potentially increase their guest speaker opportunities and experience by just being able to offer more time slots.
All right, we did have more grand round speakers this year than in years past. That is true. But, it's again, that whole engaging the audience type thing. And when you have a grand round speaker come, it's usually not just that they're walking in the door 30 seconds before and leaving immediately after, like on Zoom. No, they stay, there's discussion, there's networking that happens, project planning, that sort of thing, human interaction that can't happen or doesn't happen over Zoom when people pop in and leave the room immediately when they're done speaking. So maybe there's some benefit to, getting more people, but the quality of it, quality over quantity.
Okay, all right. Well, that was quite a debate, and I'm actually sweating a bit there. Hopefully, we can come up with maybe a hybrid solution.
Exactly. So this whole idea of where do we go from here? So there are clearly certain aspects to virtual education that have worked well for us over the past year plus, and others that we've truly missed being in person and having that that vintage learning experience. So, is there a hybrid solution? What would it look like? Is there something like maybe certain things will always be virtual? Like, will grand rounds now always be virtual? Or will there be situations where we allow certain people or certain circumstances to have a virtual format of conference education? Like if residents are post overnight, are they going to be allowed to be virtual? How do you decide who gets to be virtual and who has to be in person? If there's both options, do you give them both the same weight, the same number of credits? Is there going to be something like, is ACGME, with just like when we had independent instruction, is ACGME going to come around and say, a certain percentage of conference has to be virtual, or you have to limit it. It can't be over this amount, and that's going to be virtual. These are just kind of some ideas that we've been talking about. And I think that we're not alone in this. We'll all probably be talking about this for some time, how to kind of create this hybrid solution. Because, it was a challenging year, but maybe we learned some things for the best out of it. So if any of you guys have any ideas or thoughts or concerns, we'd love to hear them as well. And thanks so much for coming.
Yeah, thank you very much. And we're 1 minute to spare, so give us your questions.
I don't have a question. I just want to say that was a fabulous presentation style. I really loved the change up of the debate style, and especially being zoomed out at the end of the day, it was really engaging. So I feel like just the presentation style itself was really awesome. So thanks, guys.
Yeah, you should see our sepsis talk. No antibiotics first. No fluids first. No.
And there is a question in the chat. Dina, you're welcome to unmute and ask, or I can read it as well.
Sure. This is a bigger question, I think, than we have for 30 seconds, but I loved everything that you were describing, Dr. Carmelli, of all the pre-work and flipped classroom and engagement and multimodal and all that stuff. But our residents are not feeling that right now. Our residents are so burned out, and all they want to do is be near each other and just hang out and all of that. And so we can barely get them to even attend Zoom conference. They're not turning on their screens, and they're sure as hell not going to do any pre-work or play a game. So how have you found, how are you able to engage them when what they're really yearning for is less vintage learning and just more so being together?
So, that's an excellent question. And I'm noticing we were having a lot of these issues before all of this. And so if you attended any education talk in the years up till the pandemic, it was all about going away from didactics, going more towards engagement, small groups, interactive, whatever. And so then pandemic hit, and what do we do? All right, back to didactics, back to just sitting in front of a screen for 4 hours. And then we're like, oh my God, everyone hates it and they can't pay attention. Well, duh. I mean, I really think that we can figure out the virtual aspect, but we should stay true to those tried and true research methods of engagement, interactive, small groups, game. Like, as long as we're not doing that, it doesn't matter if it's in person or virtual, you're still going to lose the engagement. So I think we were just pretty bad at like moving virtual, and we just went back to old lectures, and that's really what happened.
Yeah, I think it was that plus the combination of just how truly long this has been. No one thought it was, I didn't think it was going to be this long. I mean, when we started this back in March or April, but we did include things like games and more small groups and things like that. We did really lobby for doing safe in-person sim. So our school would allow kind of 10 people to be in this relatively open area as long as they're wearing like an N95, a face mask, and essentially full PPE to do sim for like rare procedures and things like that. And that allowed them to, also do sim, but also to have that in-person experience outside of working a clinical shift. And this question is really interesting. Has any institution changed your GME budget up or down to reflect these options? Has anyone's GME come and told them that they're going to get less money for their residency budget? That would be terrible. I feel like that, I sure hope that won't happen. But, if, we're going to be doing virtual and we need to supply everyone, if, we're saying that a hybrid option is that everyone gets a chance to have a virtual option, or if you're post overnight, you can watch it from home or whatever. Then we'd kind of need some more tech, right? Some more support to get all that stuff lined up. I like the way you think.
I mean, it's hard to know. I mean, the budgets for all hospitals because of COVID has gone down, so they're probably trying to squeeze wherever they can, but hopefully that doesn't change the educational funds that much. Well, I wish we could have done this in person and filled a room and just had like a side full of people virtual and a side full of people vintage, and we could have hacked it out and then left like all hugging, like we figured it out, everyone. But that didn't happen. But who knows? Maybe next year.
Excellent. All right. Thanks everyone for coming. Take care and good luck with your education going forward.
All right. Bye.